Please watch and listen to this entire video that covers the explanation of your procedure and the informed consent process for anterior lumbar interbody fusion, ALIF. You cannot undergo surgery unless you acknowledge that you have listened and understood the entire video. The spine is composed of a series of large blocks of bone called vertebrae that are stacked on top of each other. In between each vertebra is a soft circular piece of tissue called an intervertebral disc. The intervertebral discs are tall and well hydrated, acting as a shock absorber to help stabilize the spine during movement and aiding in flexibility of the back. As we age, or sometimes after injury, the disc dehydrates and shrinks, a process called degenerative disc disease. Over time, as the disc degenerates, it is unable to act as a spacer, and parts of adjacent vertebral bodies, an area called the end plates, come into contact with each other, resulting in pain during physical activity or when the spine is in certain positions. Furthermore, parts of the disc may shift and press into nearby nerves, causing leg pain, numbness, and tingling. Lastly, in severe cases of disc degeneration, the loss of support to adjacent vertebral bodies may cause changes in the alignment of the spine, creating a deformity that can worsen posture and back pain. Common types of deformity include spondylolisthesis, where one vertebra slips in front of another, scoliosis, where one vertebra tilts to the side of another, and kyphosis, where the lower back curvature becomes flatter. One of the ways lumbar degenerative disc disease can be treated is through a procedure called an anterior lumbar interbody fusion, or ALIF. To perform this procedure, you will be put to sleep under general anesthesia and supported by a breathing machine. To begin, a general or vascular surgeon makes an incision in the abdomen and works around the internal organs of the belly to expose the front of the spine. A neurosurgeon then cuts out the degenerated disc and replaces it with an artificial spacer called an interbody that is packed with cadaver bone. The spacer is chosen to be at a specific size and geometric shape that will support and buffer the adjacent vertebral bodies into as normal of an alignment as possible. After the interbody is inserted into the disc space, a small titanium plate is placed to cover the front of the interbody to prevent it from backing out. The titanium plate is then secured in place with several small titanium screws that enter the vertebra above and below the disc space. After the surgery is complete, the incision in the abdomen is closed with multiple layers of sutures, and you are then awoken from anesthesia and brought to the recovery room. Over time, the interbody and cadaver bone that was inserted into the disc space will fuse with the adjacent vertebral bodies, forming a strong, stable, single piece of bone. Benefits. Throughout this surgery, our goal is to relieve back and nerve pain caused by degenerative disc disease by completely removing the diseased disc and replacing it with an interbody that will realign the spine. Over time, the interbody will heal into the adjacent vertebral bodies, fusing them together into a strong, solid piece of bone that will maintain correct alignment. Among patients who undergo an ALIF to treat back pain, roughly 90% report improvement of their symptoms and would repeat the surgery if they had to make the choice again. Risks and benefits. Although generally safe, anterior lumbar interbody fusion, along with all surgeries, does carry some risk. Major and minor complications range from 11 to 24%, and by watching this video, you are consenting that you understand these risks. This video covers the more common risks, and as with every surgery, it is not possible to cover every possible complication in the field of medicine. Some of the key risks are listed here. Pseudoarthrosis. In approximately 10% of patients, the interbody graft is not fully fused to the adjacent vertebral bodies, a condition called pseudoarthrosis. This can result in unstable movement between the two vertebral bodies that causes back pain. If symptoms are severe, additional surgery may be needed to help stabilize the two vertebral bodies and aid their fusion. Patients at a higher risk of non-fusion include those who smoke and have baseline less dense bone, a condition called osteoporosis. Subsistence. In some individuals, after the interbody is placed, the vertical disc space height may shorten during healing. This is a process called subsistence, and is caused by the adjacent vertebral bodies settling into the interbody. This is a common finding on follow-up imaging and occurs in over 75% of patients, with the majority having only minor subsistence. However, in a small proportion of people with weak bone, the subsistence may be significant enough to cause back pain and alter the alignment of the vertebral bodies, which may require additional future surgery. Postoperative back and leg pain is common after surgery and may even be temporarily worse than before surgery. Because the surgery alters the alignment of the lower back and increases its height, muscles along the legs and lower back are stretching, causing discomfort until the body adjusts to it. Furthermore, the nerves that run from the spine to the legs are also stretched, which may cause temporary nerve pain and numbness or tingling in the legs and feet that subsides in 1 to 2 weeks. Vascular injury. Along the front surface of the spine are multiple large veins and arteries that deliver blood to the lower extremities. These blood vessels are susceptible to injury as the neurosurgeon begins to work on the spine. Although blood vessel injury is uncommon, occurring in 1 to 6% of patients, it may be a life-threatening event due to blood loss that occurs until the vessel is successfully repaired. Retrograde ejaculation. In 2 to 6% of patients undergoing ALIF, a condition called retrograde ejaculation may occur after surgery where semen enters the bladder during orgasm instead of through the penis. This condition is believed to be caused by a disruption of a group of nerves called the superior hypogastric plexus that runs along a sheet of tissue called the peritoneum in front of the lumbar spine. Your surgeon will take care to not disrupt or manipulate this tissue layer during the procedure. Ileus. Slowing or cessation of bowel function is a common condition that patients undergoing any procedure that involves working in or around the abdomen experience. Up to 17% of patients that undergo an ALIF experience ileus, which may prolong the hospital stay until normal bowel activity resumes. Visceral injury. In 1% of cases, during the initial approach and exposure of the lumbar spine, injury to the intra-abdominal organs can occur. This includes organs such as the intestines and pancreas, as well as other structures such as the ureters, a tube structure that delivers urine from the kidneys to the bladder. This risk is highest in patients who have had previous abdominal surgeries where there is a buildup of scar tissue. Durotomy. The lumbar nerves are enclosed in a tough leather-like sac called the dura that is filled with cerebrospinal fluid and located behind the intervertebral disc. In rare instances, if there is scar tissue or adhesions behind the disc and the dura, a tear may occur in the dura as the disc is being taken out. The leak is usually sealed with a stitch or two, followed by an absorbable glue. Postoperatively, we typically instruct patients to lay flat for 24 hours to ensure it seals. If a leak occurs, one should avoid coughing, sneezing, or grunting. Signs to look for that the leak reopened are headaches when sitting up, relieved by laying flat, clear fluid draining from the wound, or a bulge in the back. Please let your provider know if any of these symptoms should occur. Persistent symptoms after the surgery are possible and can occur in up to 10% of patients. These symptoms may include continued back and leg pain and may require repeat operation. Some patients have continued back pain for unknown reasons or scar tissue. This is also referred to as failed back surgery syndrome. Adjacent disc disease. When portions of the spine are fused, additional stress can be placed on the intervertebral disc above or below the fused segment, causing it to deteriorate faster over ensuing years. This occurs in 2 to 14% of patients and typically presents years after the initial injury. If the adjacent segment disease becomes severe, it may require more surgery, including extension of the fusion. Loss of mobility. Most people lose about 5% of range of motion per level fused. 1 to 3 segment fusions do not result in significant stiffness. Infection and wound healing problems are uncommon after ALIF and occurs in less than 3% of patients. Infections can be superficial or deep and can be caused by a variety of bacteria. If the infection is superficial, it can usually be managed with antibiotics alone. Should it spread deeper, it may require repeat surgery and/or removal of instrumentation placed. Risk factors for infection include significant blood loss, longer operative times, previous wound infection, diabetes, chronic steroid use, obesity, and smoking. In less than 1% of cases, a hematoma or blood clot may occur at the site of surgery. This can compress the spinal nerves and may need repeat surgery for evacuation. If you experience new leg pain, weakness, or numbness after surgery, please let us know and we will order an MRI or CT scan. Surgery of any kind, particularly spine surgery, can be stressful for your entire body. As such, medical complications can occur in up to 5% of the time. Minor complications can include atelectasis, in which the lungs are not fully aerated, or urinary tract infection. More major medical complications can be things like pneumonia or heart attack. These are more common in patients over 60, diabetics, smokers, the obese, those with COPD, heart, or kidney disease. You should consider eliminating or mitigating these risk factors to increase your chance of a successful outcome. Mortality rate. The chance of death from surgery is less than 1%, 0.3% in 90 days. but like any surgery, it is not zero. Mortality is more likely in those with multiple medical problems, such as prior cardiac disease. Spine surgery and all anesthesia raises your risk of developing blood clots in your legs, also known as deep venous thrombosis, occurring in about 15% of cases. Risk factors for clotting in the legs include advanced age, smoking, obesity, longer surgery, extended hospitalization, immobilization, neurologic deficit, cancer, clotting disorders, and birth control pills. If a clot breaks off, it can travel to your lungs, causing what is called a pulmonary embolysis. If a pulmonary embolysis occurs, the risk of death is 1 to 2%. Postoperatively, we will prescribe compression stockings, compression boots, or blood thinners to minimize the chance of such blood clots. The best way to prevent blood clots is to walk as much as possible. If you develop pain or swelling in the calf, please let your provider know so that an ultrasound can be ordered. Rare anesthesia complications have been reported that included allergic reaction to various medications or unique side effects that some patients may experience. Specific risks will be discussed by your anesthesiologist at the time of surgery. Your doctor may do anything else he or she deems necessary at the time of surgery, which could include removal of additional levels, a fusion with screws, rods, or spacers, or other procedures. If you object, please tell your provider. Surgery expectations. You should expect a pre-op visit with your primary care or hospitalist during the week before surgery. At that time, you will undergo testing such as blood work, EKG, and a chest X-ray to make sure you are medically safe to undergo surgery. If you see a specialist, such as a cardiologist or pulmonary specialist, you will need to see them and obtain a letter clearing you for surgery as well. Please also note that the BNI is a world-class academic institution, and in order to continue providing excellent care, we teach a variety of residents and fellows that may be participating in your surgery. All key portions will be performed directly by me or under my supervision. Post-op care. Hospital stay. This type of procedure typically requires a hospital stay of 2 to 3 days, depending on your preoperative physical condition, as well as any other medical issues that need to be addressed. Recovery. Healing of the wound, muscles, and soft tissues typically takes about a month. Fusion of the bone takes longer and typically requires a year for healthy fusion to be complete. Physical therapy and rehab typically starts at 3 months after the surgery. Wound care. Nothing should be put on the wound, which typically has glue on the top and absorbable sutures deeper. Sometimes the wound is closed with staples or sutures, which are removed 2 weeks after surgery. You may shower at 48 hours. It is not necessary to cover the wound while showering. Do not submerge the wound under water, such as in a bath or swimming pool, for 6 weeks. Activity. Your surgeon may give you a brace to wear when out of bed for the first few weeks after surgery to provide additional comfort and stability. Check with your doctor, but generally walking is all that is needed in the first 2 weeks. You should avoid BLTs, bending, lifting, and twisting, for the first month. Exercise should not be vigorous in the first 6 weeks and limited to mainly cardiovascular. Golfers can usually start putting and chipping at 6 weeks. Additional guidance on physical activity will be given when you return for follow-up and during rehab and physical therapy. Return to work. You can generally return to work in 2 weeks if your job is mainly desk work or sedentary. If you perform strenuous physical activity, longer recovery may be needed or limited duties imposed if you return sooner. You should discuss the specifics with your provider. Thank you for watching this informed consent video. Please contact your provider if you have any further questions or concerns.